Good day. Thank you very much. I'm Antonia, Barnard. I'm from the city of Johannesburg, and thank you very much for the opportunity to present the Johannesburg experience in the case study of COVID 2019 at this conference. This presentation is going to cover where the city are in terms of the 1990 strategy, some COVID trend data, COVID-related interruptions or disruptions in terms of health services, and mostly focusing on policy innovation and program innovations that we conducted. On 16 February 2018, the President of South Africa, Cyril Ramaphosa, announced the intent of South Africa for the year 2020. And that indicated that by scaling up our testing and treating campaign, we will initiate an additional 2 million people on antiretroviral by December 2020. And as at March 2020, we were already achieving on the first 90, 86%, on the second 90, 77%, and on the third 90, 84%. The performance might not be as some of our first world countries, but just to note that South Africa and Johannesburg in particular has 677,000 estimated persons living with HIV. And as at March, we had 409 of those patients on antiretrovirals. So we had a very large epidemic compared to other cities that will be presenting at this conference. Trend data in terms of COVID-19 in South Africa, as at the 10th of September, we also had a very large COVID outbreak, and we had 642,451 cases at the 10th of September, with a case fatality rate of 2.4% and a total number of recoveries at 88.7%. This graph shows you the trend of the data in Gauteng province, where we are located, with the pandemic starting on the 5th of March in Gauteng province, where the first case had happened, and then the 26th of March, where the president then announced the national lockdown. And then slowly, as lockdown was released, the increase in the number of cases, and the epidemic peaked at the mid of July, and you can see how then the cases decrease. This slide shows you just a distribution of cases throughout Johannesburg. We have 7 functional units, and most known to the world is Soweto, and that is Region D. And you will also note that they have had the highest number of cases to date, followed by Subdistrict E and Subdistrict F. In terms of the cases by age and gender, the females contributed to the largest proportion of cases, with 57.6% of cases being females. And then in the age group of 31 to 40 years, there were 27.5%. However, the risk remained the highest amongst the 80 years and older group, with the highest incidence risk there. In South Africa, we have a mix of population. On your right-hand side, you see the Alexandra Township, as well as Sandton affluent area and the skyscrapers of Sandton. The low socioeconomic groups were mostly infected, and they were at most increased risk because of the densely populated informal settlements and township. The social distancing was very difficult. Closure of most formal and informal settlements, businesses happened due to lockdown. As a result, this had a serious effect on our vulnerable population cells, our low-income earners in informal employment, who lost their jobs and then were faced with food insecurity. So South Africa and Johannesburg in particular were suffering or had a problem with gender-based violence, and this increased during the COVID outbreak. The health department's approach to the COVID outbreak was based on 6 pillars, and it involved a health response, a food and security and social relief response, municipal services, economic social mobilization and human solidarity, and law enforcement and compliance. The health response was based on a dashboard that was monitored on a weekly basis, and it included the activities related to screening, testing, contact tracing, and healthcare capacity to deal with the outbreak. One of the interventions that was done was mapping of the outbreak to guide us as to where are the highest burden areas, the hotspots wards. And in the hotspot wards, we had huge community campaigns happening, awareness campaigns, where persons could be tested and screened, and there was door-to-door screening of people, and environmental health was on site, teaching about social distancing, wearing of foot masks, food safety, and hand washing. Social development was also on site, and training communities about gender-based violence. The impact on the health services and the utilization started after the lockdown, which was on the 26th of April. The headcount fell significantly in April, which you can note on the graph, where we had an average of 600,000 headcount attending to our primary healthcare services on a monthly basis. This fell down to April, very low in April, and then May it started picking up. And the most reason was that generally the community did not want to come to health services because of fear of contracting COVID at the health facilities. In terms of the impact of HIV treatment cascade, you can see the same happening, that there was a decrease in the number of new persons living with HIV diagnosed in the period. There was less tests done, and the ART initiation was then less numbers. However, when you analyze the data, we actually had a better linkage to care during this period. The reason also why the testing decreased was our COVID teams our outreach teams were directed to the COVID response. So in Johannesburg in particular, we were running a project called the Putuma Project to enhance and working towards achieving of the 1990 targets by December 2020. And this project started in September 2019. During this period, we were doing a lot of cleaning up, updating data, following up on persons waiting for ART, cleaning of our persons lost to follow up. And as a result, you could see a very nice trend how we increased our patients living placed on antiretrovirals. Then after the COVID outbreak, persons living with HIV moved around. There was migration back to their homes. They lost jobs. So there's a total move of our patients. And currently, we started, you could see a comeback in June 2020, but then again in July, data did not look so good. So there's a massive activity to follow up on finding of our lost to follow up patients. The same happened with our TB because there was lesser headcounts screened for TB symptoms. There were lesser TB patients diagnosed, and the linkage to care remained very good. It's always around about 98%. And so far, you can see in all our services, antenatal care, cervical screening, and couple-year protection rate, the impact of the COVID outbreak was there, also including on sexually transmitted infections. So in terms of our staffing being affected, that had a major impact on service delivery at primary healthcare facilities. Overall, for the city of Johannesburg, we had 1,821 confirmed cases. That was at the 7th of September. 104 were still active, and 1694 had recovered. In terms of health services, was severely disrupted due to infected staff and those contacts of the infected staff, leading to a number of people being in isolation and quarantine at the same time. 301 persons tested positive, and we had 3 fatalities by the 7th of September. How we managed the situation, when we put a shift system in place, it started to work much better. So how the COVID outbreak was managed to improve service delivery and access to services, we reorganized our primary healthcare services, and you could see on the diagram there was one entry, and patients were screened. Those with signs and symptoms were seen in the orange areas, and those with no signs and symptoms were then referred to the normal service delivery area. And the signs and symptoms area was totally outside of facilities where we erected tents, and you can see we've got a respiratory tent, HIV screening test, a medical care tent, as well as the COVID screening happening in that area. And then the clients never passed each other again, they exited at different exit points. In terms of the gender-based violence, we do have a package that's offered, and during this period there was high numbers of gender-based violence, even from the first week reported, and as a result the city then established a 24-hour crisis telephone line where people could call for help. One of the main activities to assist with the primary healthcare service delivery was the decongestion of patients attending to suffering from chronic diseases such as HIV/AIDS, hypertension, diabetes, epilepsy, and asthma. And we implemented the multi-month scripting quite some time ago, about 2-3 years ago. However, this was extended during this period, and patients could collect their medication at external pickup point. We increased our number of external pickup points. We do have a lot of options for our patients, which includes at corporate pharmacies, pharmacy dispensing units, post office, collect and go lockers, and chocolate containers. With the multi-month dispensing, scripts were written up to 12 months, which helps the patients only to come back to facility for re-scripting in 12 months' time. We've also started the home delivery for uncontrolled patients, and this is a pilot that is currently being run, and a huge marketing campaign of the decanting services that we offer. This is just pictures of external pickup points. The PDU is like an ATM type. The collect and go lockers is a locker. The patient receives the SMS and then is able to note his medication is in the locker, and then he could collect the medication. Also, shelf left containers helped us where they are no corporate pharmacies where people can pick up. So these containers has been placed at accessible places for the community. Another innovation was to expand on our HIV self-screening project to see what yield it would be. This was to prevent and assist with the prevention of the spread to our HIV testing counsellors, as social distancing was better when we encouraged HIV self-screening, and we find a good yield from using this modality. In terms of reaching our key populations, we our service providers for the key population all mostly reverted to using social media. You can see on the screen there's a WhatsApp that was sent to adolescent girls and young women attending our psychosocial working groups that we have. We also inserted some materials for education materials for the youth, where they can get more information about what is COVID and what is happening and how to manage that. In terms, you can also see that in the top left corner there is the engagement health message to the LGBTI community to say there are many myths circulating about the cures for COVID-19 and HIV. Only follow health advice from reliable sources. And to manage also in this time, we also made use of telephonic communication with clients on treatment to ensure adherence and improve adherence. This slide just shows you some other social media platforms that was used to communicate with our sex workers. So what was the lessons learned in relation to the emerging pandemic and the preparedness and HIV/TB response resilience from the urban COVID-19 epidemic? The epidemic caused a decrease in the numbers seeking healthcare at our facilities. However, and a number of patients are lost to follow up as a result of that. But the drop in the headcount was significantly higher than what we saw in terms of our HIV program. And that is a reassurance to us that we have a strong base with our patients having a resilience to look for their treatment and make sure they don't interrupt treatment. We also found that the HIV, the COVID screening, where it presented opportunities in the community for HIV and TB screening. So the HIV response should be focused on reaching those that have not been reached before through the COVID screenings that was happening in the community. The further value of the lesson learned was that the early decanting already at 6 months, when our clients show a viral load suppression, we could write scripts extension, and it allowed for the safe, convenient collection of medication at external pickup points and not at facilities. Social media can spread a lot of misinformation. The government and partners should actively put social media messengers on an ongoing basis to counter misinformation and causes panic amongst the community at large. We had a very good joint response from private sector and government working together, and private businesses offering some services to the public health sector, such as assistance with shelters, PPE donations, food parcel donations, and that assisted a lot because of the demand in the community. And it is important that we learn from the lessons of COVID, and that we know that we are ready next time or when this has happened. So new emerging epidemics can derail all planned activities as we as the city plan to reach our 1990 by December 2020, and now all the plans are derailed. So the pandemic also showed us the usefulness of technology, as we were able to use virtual platforms, social media, to communicate with large members of the community, as well as staff and other stakeholders. I thank you for the opportunity, and for more information, you can send me an email. My email address is on the screen. Thank you so much.
It is my great pleasure to share Rwandan case study. I'm gonna present COVID-19 situation in Rwanda, and this part will be followed by HIV service delivery, TB, and maternal and child health services amid COVID pandemic. So I would like to start my presentation by sharing how COVID-19 response is structured in Rwanda. As you can see on the slide, there is a national coordination structure, and this structure is managing the response in the country. And the team is made by a multidisciplinary team. As you can see on the structure, there are different profile, medical doctors, epidemiologists, experts in logistics and planning, and we have also experts in communication. All of that to make sure that the pandemic is well managed at country level. I would like here to share how COVID-19 data look like in Rwanda in the period of March up to 9th September. So as you can see on the left side of the slide, from March up to August, there was a gradual increase of COVID-19 cases. But as you can see in August, we had a sudden peak of COVID cases. On the right side of the screen, you can see the overall picture of the COVID-19, where we have overall cases at 4,460. And among those 2,326 had recovered, and we had 21 cases. By this date, we have 2,113 active cases, and the capacity of laboratory testing is within 24 hours is at 3,805 tests. Overall, since the pandemic started in Rwanda, 408 tests have been conducted. Down on the screen, you can see age distribution of COVID cases, where we have majority of them between the age bracket of 20 to 39 years. So this is the slide that is focusing mainly on the city of Kigali data between March to September 2020, where also the trend is similar to the national trend. Also, there was a gradual increase, and then there is a gradual increase, and then we have a high peak in August 2020. So looking on the 3 districts of the city of Kigali, we have 3 districts, Gasabo, Kicukiro, Nyarugenge. But you can see that one of the districts is most affected by COVID-19, which is Nyarugenge district. But we can notice that across the district, men are most affected by COVID when compared to female. Also, we did analysis of the city of Kigali data by gender, and as I initially said, men are mostly affected by COVID. As you can see, it is up to 61% compared to 39% of female. Now looking on data disaggregated by age category, we can notice that a majority of COVID-19 cases and the age bracket between 20 to 39, where we have majority of people who are infected by COVID. And as we can see across all age brackets, men are most affected by COVID-19. So for the management of COVID-19 in Rwanda, different approach and methodology are being used. And here I would like to highlight different technology that are being used currently for the management of COVID-19, where I would like to highlight the use of geographic hotspot mapping to do contact tracing, the use of robots, the use of thermal scanning camera, and the use of drones. So from this overview of COVID situation in Rwanda, now I'd like to present some service delivery disruption amid COVID-19, and I'll be focusing on HIV, TB, and maternal and child health services. Starting by HIV service delivery, we did analysis of HIV service delivery between July 2019 and June 2020, just to identify if there is any potential disruption of COVID through, out of routine service delivery. So as you can see on the left side of the screen, there was a slight decrease of people who are initiated on ARV treatment, both at national level in dark blue and light blue. This is data for the city of Kigali. But as you can see, starting by April 2020, the program picked up, and the number of people who were initiated on ARV treatment increased. And we think that also those who were not able to initiate on treatment during March, where the strict lockdown measures were applied, also were captured in the program. So as I was speaking on disruption of routine HIV service delivery due to COVID, I would like to highlight the role of different prevention measures of COVID on routine service delivery. And those one mainly include the national lockdown that was initiated in mid-March, restriction of movement and others. And services that were mostly affected include HIV service prevention and care and treatment services. Specifically for HIV prevention services, outreach services for HIV testing were put on hold, and beneficiaries, including key population, adolescent, young girls, and women, were not reached by HIV testing services by that time. Another prevention service that was affected is condom distribution through social marketing. For HIV care and treatment, the challenge highlighted is mainly delays in drug refill. As I highlighted, there was restricted movement during the lockdown, so we had some delays of drug refill. Also, we noticed poor adherence for people who are on treatment, and food insecurity, especially for people who are working in the informal sector, and those many were most affected by lockdown measures. Also, we noticed the different challenges to supply chain, and those challenges also lead to delays in RV shipments. Focusing now on the city of Kigali, we did analysis of HIV service delivery, focusing on patients starting antiretroviral treatment, and then HIV testing and counseling services. This analysis looked on the 3 districts that are making the city of Kigali, and for starting with the patient starting on RRT, we can notice that like national data in April, we had a decrease in people who are starting antiretroviral. Then in April, where the lockdown measures were released, and the number of people initiated on treatment increased. The same applies also for HIV testing and counseling services across the 3 districts of the city of Kigali. Yeah, given those different gaps and challenges that the program was facing, different strategies were adopted to make sure that we are sustaining HIV service delivery. And this was a joint effort between the national program and different actors, especially the network of people living with HIV and civil society organizations that are implementing different interventions in HIV response. Starting with national program, there was a reinforcement of multi-month drug dispensing strategy, whereby unstable patients were given 3 months stock, and where stable patients were given 6 months drug stock, to make sure that we are limiting their movement to the health facility and potentially the risk of being infected or exposed to COVID-19. Also, to give guidance to health facility, a specific SOP was developed on HIV service delivery and COVID-19. As I said, we have different interventions that were implemented by different actors. Here, I would like to highlight the essential role played by a network of people living with HIV, which put in place a system of community follow-up of people living with HIV, mainly using phone calls. And also, this network put in place a free line to quickly respond to people living with HIV needs. And also, another strategy used is to make sure that peer educators are reaching some of the patients at home to make sure that they have the access to their treatment. Also, this network contributed to the identification of people living with HIV with food insecurity, and they were linked to the program to have access to nutrition support. I would like also to share the contribution of civil society organization, which played a key role in awareness of key population on COVID prevention using different media and other communication channels. And also the organization identified key population with poor adherence, who received appropriate counseling to keep them on their medication. Now talking to TB, tuberculosis program, here I would like to share the trend of tuberculosis case notification, and here to understand potential impact of COVID on tuberculosis service delivery, we did analysis of TB case notification between January-March 2019 to 2020, and then between TB case notification between June 2019 and 2020. As you can see on starting with the left side of the screen, there was a slight decrease between the period of January to March 2019 as compared to January-March 2020. And looking on the period of April-June and April-June 2019 and 2020, there is an increased decrease of case notification for those two periods. So different strategies were put in place by the TB program, and I would like to highlight instruction that was released to support treatment adherence by providing 1 month's treatment instead of implementing routine direct observed treatment. Also, health facility were advised patients to be treated at community level instead of coming on regular basis to the health facility. There was a great role of community health workers that helped to correct sputum for bacteriological follow-up of patients. Also, there was a provision of personal protective equipment to community health workers who are supporting TB program at community level. Lastly, health facility screening TB for patients also screened for COVID-19 for those who were presenting symptoms of tuberculosis. So now looking on maternal and child health services, here we selected some program like antenatal care. We highlighted also assisted health facility delivery, and lastly, immunization coverage. So for the 3 programs, we did analysis of data between January to April 2020 to see if there is a decrease of service coverage and uptake during the implementation of lockdown. So as we can see that starting on the ANC coverage between January to April, and ANC in blue, there is the proportion of ANC utilization. Red, there is ANC first started visit, and green, we have also ANC first standard visit. So as we can see that there was no really a decrease during the application of strict lockdown in March. The same also is health facility assisted delivery, where you can see the trend remain stable between 92% up to 97%. And especially for March, there was really no decrease of health facility service delivery. On immunization coverage, the same between the January to April. All the vaccine package, as you can see on the slide, BCG, polio, and others, the coverage remained the same. So here I would like to share some recent learned. So recent learned for this COVID-19 response, and especially the sustainability of routine service delivery, It is important to have high-level leadership in COVID-19 response. As I highlighted, we have a national coordination structure, and this is chaired by the Prime Minister's office. Also, effective communication is really important to increase accountability of everyone. Here, I would like to share an example of how Ministry of Health on daily basis report on COVID cases, like the slide they have shared. I would like to highlight the national campaign on COVID-19 prevention that is being organized by the National Police. I would like to highlight the great role of media in awareness raising, and also I would like to highlight the great engagement of civil society organization and community mobilization on COVID-19 prevention measures. Another lesson learned is about effective control of COVID-19 that require multi-sectoral collaboration and partnership. And here, really, we experienced this approach from a great collaboration between government, partners, civil society organization, and the general population. Lastly, I would like also to highlight the importance of using different innovative technology in the management of COVID-19. So for sustaining high quality services, including HIV, TB, and maternal child health program, really quick adaptation of national strategy and service delivery models was instrumental to sustain high quality and coverage of HIV, TB, MC, and maternal and child health services at national level. Also, close monitoring of key indicators was essential to inform necessary strategy to be implemented as I initially presented. I would like to acknowledge the role of community health workers, which is really important to ensure the continuity of services and support of follow-up of patients at community level. This was mainly highlighted in the area of tuberculosis program. Also, specifically for HIV program, the involvement of network of people living with HIV and civil society organization was critical to provide treatment adherence support and addressing the challenges of service beneficiaries. So I would like to end this presentation and thank everyone for your attention.
So I'm Professor Lloyd Mulenga from the Ministry of Health. I'm the Director for Infectious Diseases. And would like to look at how we have performed, especially during the COVID era, in terms of the HIV response. So as a country, by August, we had seen that a number of infections were happening countrywide. The total cases that we had seen were 12,836, with a case fatality rate of 2.3%. By then, in Zambia, we had lost 295 patients due to COVID, and active cases were 793. Now, as the director responsible for all the COVID response in the country, and I'm also responsible for the HIV response in the country, we had to make a lot of interventions for us to try to minimize the effect of COVID on other services, including HIV. We had, of course, seen that the cases had been increasing, and as I said, in July to August, that's when we had the peak in terms of the cases. And we had seen that the high admissions and mortality were among men, and also the Asian population in the country, 45 years old, and diabetics and hypertensives were largely the people that we lost due to COVID. And the reported cases were from urban and also the border towns. In fact, the initial stage which we had is on the Tanzania border town in Nakonde. And this was related to high movement of individuals crossing over between the two countries, Zambia and Zimbabwe, especially truck drivers. And we saw that the burden now increased in July to August when we had a high number of cases. And we had to conduct a seroprevalence survey for us to understand the prevalence of SARS-CoV-2. And in this, we did 3 surveys. We looked at the general population where we randomly selected enumeration areas in 6 districts in the country. Now, these 6 districts which we chose, Kabwe, Livingstone, Lusaka, Nakonde, Ndola, Solwezi, and Lusaka, we selected them because these are the districts where we had the initial cases for COVID from 18th March when we had the first COVID case, which was an imported case from France. This spread across these 6 districts. So I wanted to understand the prevalence of active disease in these 6 districts. Then we also went into understanding those who are accessing the health facilities in the OPD, the outpatient departments. We also selected 20 health facilities for us to understand the burden of both active and also a previous infection due to COVID. And because healthcare workers had also been seen to be infected with COVID, we also sampled 20 health facilities and conveniently looked at a select number of healthcare workers, again, to understand the burden of active COVID infection and also previous or past infection. Now, when you look at these 6 districts, it represents about a quarter of the total population of Zambia. So it gave us some understanding of really where the burden was for COVID. And when we did this prevalence study, it was during the peak time when we had in July the number of cases increasing until end of July. The study was from 2nd to 30th July. So we did the study at a peak of the infections due to COVID. When you look at the distribution of age and sex, majority of the participants were female with 61%, then 39% being male. This was in the household survey, but also in the outpatients and also the healthcare surveys. We saw that a high number of patients were female patients or participants, rather. Then in terms of age, it is the age from 10 to around 49 across all the 3 surveys. And we compared this population which we sampled in the surveys to the population matrix which we have in the general population as obtained from the census. And it was also identified that in the general population in Zambia, we have more female compared to male, and also the distribution in terms of age also is from 10 to 49. So we are confident that the sampled population was representative of the community. Then we looked at the results, the prevalence. We found that in these 6 districts, which as I said, represent 25% of the Zambian population, the household survey revealed about 8% SARS-CoV-2 positivity, and also for serology indicating the previous infection, it was about 4 to 5%. And when we looked at the outpatients, similarly in the outpatients, those individuals who are coming to seek services as an outpatient, the prevalence was higher, about 13% of having active infection, and serology was also higher, indicating previous infection to about 6%. And for the healthcare surveys, it did agree for the healthcare worker survey with the household survey with a prevalence of about 7%, and serology about 3%. Then again, tried to look at this data like prevalence by age. We found that largely it's the same age group 10 to 49, which was highly affected, with a peak of infections happening in the age group of 30 to 39. Then also, when we look at the prevalence by sex, more males were infected compared to the females, with the household survey showing us that close to 8% positivity in the male population compared to about 6% in the female population, although the confidence intervals were overlapping. And After understanding this, we also wanted now to relate the impact which COVID had on the HIV services. We had seen that there was a reduction in community and also facility HIV services, as evidenced also through the low HIV testing services. The new positive and the new patients who are started on ART had reduced. However, it was too early for us to tell the impact of the COVID-19 on viral load suppression and also on retention in care. We also had seen that COVID had put challenges on us on the supply systems, like for certain ARVs, abacavir, tazanavir, and also the TLD. There was a shortage of these ARVs in country, and some of those were global, like atazanavir. And we started moving patients who were on TLD, we started giving them the tenofovir, lamivudine, and efavirenz instead of the tenofovir, lamivudine, and dolutegravir. So the DTG or dolutegravir transition had to slow down because we did not have the required commodities due to COVID. We had seen a reduction in the number of flights which were coming in, and we had also seen a reduction in number of trucks as well, which were bringing in the ARVs across our border towns, largely from South Africa. And this is the data again showing us the reduction in HIV testing services across the provinces. Importantly is to look at the national trends, where we see that in April 2020, we had a reduction compared to the January 2020 in the HIV testing services by almost a third. And we attributed this largely to COVID. Then also the new HIV positive cases from January to April, again, we saw that there was a reduction, about a quarter as well, in the number of new positives that were seen during the same period. And again, we have put for us February, because February is the time, January is the time when we started having our neighboring countries presenting with COVID cases. But for Zambia, their first case came in March. But we have tried to compare from January, when we had ramped up the activities towards COVID, and also we started doing certain interventions to mitigate the fear which was around many people getting COVID in health facilities. Then again, the number in the patients started on ART during the period. Also this, we saw the reduction. So we saw the reduction across the whole cascade. The number tested, we saw the reduction in the number of individuals that were also being put on treatment. Then the mitigation measures. We had a number of mitigation measures put in place. As I earlier said, because of reduced numbers of the commodities that we had, the dolutegravir-based compounds, the TLD, we had to start switching patients from TLD to TLE. Then we started also implementing the month dispensation of drugs, where we are giving 6 months so that these patients do not have to return back to the facilities within a short period of time for fear of them getting COVID. And the decongestion strategy at ART sites did work for first line and also second line, and also for pre-exposure prophylaxis. We designed a system whereby the 6 months dispensation was available across all these populations. Then we enhanced the central level collaboration. We have various partners, the Ministry of Health, the Global Fund, then the paper supported agencies, the USAID, and also the PSM, who are the logistics management entity for the US supported supply system. We had to have bi-weekly meetings for us to look at how we would streamline the distribution of commodities from the point of entry until they reach the Medical Stores Limited, which is our storage and distribution entity in Zambia. We also had to look at resource mobilization for additional funding for procurement of TLD, which was in short supply. In second line ARVs like lopinavir and ritonavir, which was also in short supply, had to be switched to start using atazanavir, ritonavir. And the active ingredients, the APIs, were also low, we're told, because Asia, by this time, Asia and China, where most of these APIs were coming from, was highly affected by COVID. Then we had to design scenarios where we had to ensure safety first for patients and also for the healthcare workers. So healthcare workers, we had to provide the personal protective equipment, emphasize the physical distancing, and also triage as well. And to reduce the risk of transmission to patients, the facility screening and also isolation centers were set up in the large facilities, and also emphasize minimizing contact with health facilities, and we enhanced infection prevention control measures. So the month-to-month dispensation has been a success for us where possible. Sometimes we're even calling the patients to come and pick up the drugs. This was avoiding the full clinical interaction just by making a call. Then also we would have checking on them with how they are adhering to therapy, and would use this opportunity to inform them of further COVID-19 prevention measures. And if someone was eligible for viral load testing, a call would indicate to them that they needed to come to the health facilities. We also scheduled appointments in a spaced manner, and also the weekend and after hours were also opened up. And as I said, we also aligned the month-to-month dispensation of drugs, ARVs, aligned to that of the TB preventive therapy for TPT, so that they could also be given the similar amount of drugs for the number of months that they were dispensed ARVs with. And we engaged the community as well. The community index testing has now resumed, and we had to train community health care workers. But besides that, we needed to give these community health care workers personal protective equipment, especially the face masks, and also to have gloves as well, sanitizing. And we made a national policy on face masks as well to the whole country, although the adherence was not 100%. But these measures were meant for us to protect the public and also our healthcare workers. This is what we saw over time. The improvement in the 6 months, the dispensation, we saw that by April there was a rise in the month dispensation in Lusaka, where we had close to 70% of patients on month dispensation, as opposed to 8% when just we had the first cases of COVID. So we enhanced and we used this as the first model for accelerating the month dispensation of ARVs. We largely relied also on the ECHO platform using the Zoom technology, where the HIV, TB, and clinical programmatic mentorship has been used before for us to mentor. Now we use now the COVID-19 mentorship series via the ecosystem, and we integrated the COVID-19 and also HIV, TB mentorship. Now this was done earlier on before we had the first cases, and we continued doing this through the pandemic, and we have continued using the ECHO platform for mentorship, both for COVID and also for HIV. Now over TB in Zambia again, like other essential health services, the delivery of TB services had also been affected by COVID-19 pandemic. Since those first 2 cases we are seeing in mid-March, we had to devise modification of the delivery of the services, and also this resulted as well in a low turnarounds for patients in the outpatient departments, and this resulted as well in the reduced numbers of presumptive TB patients being identified. Inadvertently as well, the TB notifications, they plummeted. We started seeing reduced numbers in the notifications. And this has been the impact of COVID on the on TB. And we saw that from the first 2 cases, we had a reduction in the number of the TB presumptives and also the cases which were examined in the laboratories. We introduced the situation room where we started looking at the data daily and also engaged ECHO system or platform for us to do mentorship. And we've seen now a gradual rise in the number of patients that we are identifying, and also the notifications and the examinations in the lab as well. The TB preventive therapy was also affected, and after looking at granular data as well, we started now seeing an increase in the number of TPT, even the completion rates and also access to TPT services. So the lessons learned is that COVID-19 pandemic response, we have tried to leverage on the HIV TB. The lessons learned were that the COVID-19 pandemic response has leveraged on the HIV TB program systems which have been implemented at all levels from community, facility, and also management levels. Then the use of the virtual platforms for mentorship, at program level, supervision, this has also helped the program fight COVID-19. Then the way that we are looking at the data granularly, and also helping us to inform the managers in terms of distribution of commodities, did avert the stockouts. And with the interventions which we had of trying to substitute certain ARVs with other ARVs, was something which led to us not to have patients go out without drugs. Then the continuous quality improvement interventions were key, and these have sustained some of the program-related indicators, or else we're going to have very, very poor outcomes as related to the HIV indicators as well. So this is how we have tried to manage the HIV program, and we've tried to avert some of the catastrophes which would have encountered if we had not put some of these things in place. Highly, I think for me, is that the COVID-19 benefited a lot from the HIV response, in that we have set up systems using the HIV response, and those systems, we used them to strengthen the COVID-19 response. But also the issue of mentorship, which we had using the HIV, using the virtual platforms, was very key. And also us analyzing data, informed data in various facilities was very key. Thank you so much. This is our experience from Zambia, and we are grateful that we could be considered to share our experience.
Good afternoon, good morning, good afternoon, good evening. Bom dia, boa tarde, boa noite. From Mozambique, I am Bélia Xirinda, Director of Health in Maputo City Council. And this is the case study for Maputo City. These are the contents of this presentation, mostly about COVID and the current situation of HIV/AIDS in this country. Well, this is the country. We are in the eastern coast of Southern Africa, and we are near South Africa, Swaziland, Tanzania, Zimbabwe, etc. And the capital city of this country is Maputo. These are the demographics. We have a population of more than 1,000 million population in Maputo City. And we have 36 health facilities, including 6 hospitals. The doctor inhabitant ratio is 1 per 5,559, and the ratio nurse inhabitant is 1 per 754. The number of people living with HIV/AIDS is more than 144,000 population, and we have new infections estimated every year more than 3,700. And the prevalence of HIV in Maputo is 16.9%. It's very high. And Mozambique is the 6th country in the world with the highest prevalence of HIV. This is a chronology of COVID-19. Our first case we had on 22nd March, was our first COVID-19 case diagnosed. It was an imported case. On the 30th of March, we had the declaration of state of emergency by our president. On April, we had 15 cases, and we created a center for COVID victims. May, we had 33 cases, and we intensified our testing capacity. June, on the 18th, we had our first death from COVID-19, and we had 22 cases. July, we had 223 cases. August, on the 10th, we had the declaration of community transmission because we are having exponential rise of the COVID in the city. And we also, in August, we did a prevalence study because of this pandemic. And we had 951 cases. Currently, till September 9, we had 1,781 cases of COVID and 15 deaths. And if we compare Maputo city with another province, we have the most of the cases of COVID-19 are in the capital, Maputo city, more than 25%. This is a national summary of COVID-19. So we have more than 1,000 tested positive. We have 4,064 cases of positive cases of COVID-19. 28 deaths in all the country of Mozambique. About Maputo city, I spoke about the number of cases that we had for each month, and the distribution by gender, we have 54% are male and 46% are female. About the age groups, most of the cases are between 25 years old till 50 years old. About the prevalence study that we did on August, we used the qualitative rapid test, Abbott, that detects the presence of antibodies against the new coronavirus, IgM and or IgG. We had 10,237 participants. Among those, 54 were professional groups and 46 households. Among these professional groups, we had military forces, we had cops, we have drivers, grave diggers, shop sellers, market sellers, etc. These study, the duration were 19 days. In the preliminary results, we had the community exposure rate for about 3.79%. Adolescents, young adults, and elderly people are more exposed to this coronavirus, 44%. All professional groups are affected, with market and store vendors most exposed to the new coronavirus. Market employees have the highest SARS-CoV-2 exposure rate, about 5.22%. Among health professionals, laboratory technicians have the highest exposure rate, about 3.64%. Majority of those exposed are asymptomatic, about 70% were asymptomatic. The current situation of COVID in this municipality, we have a positive rate of 12% and 15 deaths. About HIV in Maputo city, if we compare 2019 with 2020, we can see that we have a decrease of the numbers of people that starting ART. We have a reduction of about 16%. This was due to COVID-19 because when we declared that we had COVID in Maputo, people were afraid to go to the hospitals, to health units. And about people active doing ART, we had a decrease of about 1%, if you compare with the same period of 2019. This is about the progress towards the UNAIDS 1990 treatment, that we have 107% who are living with HIV are aware of their status. Among those aware of their status, 101% are on ART, and among those on ART, 82% have viral load suppression. And at the right side, we have the cascade of Mozambique overall. So if you compare to the Mozambique with other provinces, we have better numbers about this cascade. So we are doing a lot to achieve these results. Impacts of COVID-19 on the HIV/AIDS program. Well, some services for people living with HIV were interrupted, especially community activities such as counseling and testing in community, as well as household follow-up visits. Community visits to support adherence and engagement in care were replaced by phone calls made by care providers and community workers. In order to keep providing care to people living with HIV, the following pillars of uninterrupted provision of HIV service are being observed, such as reinforced infection control measures and patient education, reduce patients' visits to health units for 3 to 6 month ART delivery and 6-month appointments, implementation of the policies and operational norms of the HIV program in the best way in the context of national emergency. Also, for child consultation at risk for HIV, we suspended the home visits to support adherence of ART, and we are now using a telephone to reintegrate or engage in ART. We reinforced the identification and inclusion in differentiated care models, quarterly dispensation, adhesion clubs, etc. Also, quarterly ARV dispensation for those on ART for more than 3 months, regardless of CD4 and the viral load, as long as they are in good clinical condition. Psychosocial telephone support for everyone for more than 3 months of treatment, support and reintegration interventions. And also, we created an additional ART pickup points to reduce high flux of patients in pharmacies and in the health facility, management of queues and spaces of health units by administrative assistance, supply chain for drugs and consumables, intensification on the monitoring of ARV stock, treatment drugs for opportunistic infections and prophylaxis, and guaranteed availability of ARV for quarterly delivery. About human resources, we allocated the lay personnel to disseminate educational messages about COVID-19 and also including HIV/AIDS, and also support the integrated flow of screening for suspicious signs and symptoms of COVID-19. This graph shows the percentage of patients in differentiated care models. Before COVID, we were having this patient with these care models, but it was not as we have now. In January, we had 69%. Now, August, we had 93%. So we increased patients in these care models. These differentiated care models are examples of quarterly dispensation, rapid flux, etc. Impact of COVID-19 on the HIV/AIDS. Well, we have these lessons learned in relation to emerging pandemic preparedness and resilience to response. People living with HIV, because they already have a chronic pathology, they are the most careful with their health, obeying preventive measures. They serve as a good example for other people. The use of masks here became very common, and people are obeying these. Among all, massification of the successful use of virtual platforms for mentorship and patient monitoring. And impact of COVID-19 on new users in family planning consultation. We also had a reduction. If we compare with 2019, in this green line we have 2019 and red line 2020. So we had a reduction of about 46%, very high. About continuity of family planning services, provision of door-to-door family planning methods by maternal and child health nurses, thus avoiding clusters that mobile brigades could cause, training of other community agents in order to spread the supply of contraceptives in the community. This is another topic for this case study is about Maputo, people who use drugs center. This is the first that we have in Mozambique, and this first is in Maputo City. And the MSF, Médecins Sans Frontières, that is Doctors Without Borders, they are leading this center. So this is an integrated biological behavioral survey among people who inject drug, showed that 50% of HIV prevalence and 44% of people with hepatitis. This was a survey conducted in 2003. The mode of transmission study in Mozambique, 29% of new infections by key population. Also about this center, the background information is current law criminalizing people who use drug in revision. Currently, no actors providing harm reduction services besides Mafalala Pilot, that is the name of this center. Willingness from government to move towards harm reduction, Minister of Health, Cabinet for Drugs, Prevention and Traffic, National AIDS Council. And also WHO, current consultancy supporting Minister of Health on harm reduction plan. So the center, this center about harm reduction package, they have antiretroviral treatment. They distribute needles and syringes. They prevent and treat STIs. They manage the viral hepatitis. They manage tuberculosis and overdoses management. They also support people with information education. They distribute condoms. They do the HIV testing and counsel. And they this year they started the opioid substitution treatment. They are using methadone. Achievements: first, harm reduction intervention in Mozambique, high community acceptance, harm reduction plan and guidelines being drafted, law revision being currently revised, aiming to ensure harm reduction. Challenges: low women-men ratio, prioritizing access to healthcare to people who use drugs, no guidelines or the full harm reduction service available, great impact of criminalization of drug use on access to health services, utilization of harm reduction services seemed by enforcement of paraphernalia laws, way forward, differentiated models of care, including decentralization of care, harm reduction guidelines, increased needles and syringe distribution coverage. So these are some images. Now about mental health and COVID-19. Some of the most common manifestations of mental disruptions in times of the pandemic are the acute reactions to stress and the burnout syndrome, especially among health providers. A timely intervention is needed to prevent a more serious condition like depression and suicide attempts. Preventive measures adopt provision of psychological support focused to positive diagnosed patients, their contacts and to health providers, teleconsultation line with clinicians, quarterly dispensing of ART for all mentally compensated and stable patients. We have a call center for this psychological support in response to COVID-19. The total teleconsultations were more than 3,000. Some were positive cases, new cases, and also follow-ups. And among these 3,000, 10% were health workers who had some signs of burnout. So thank you very much from Maputo City Council. Muito obrigada. Bye-bye.
Good morning, and thank you for giving me this opportunity to present to you the HIV response in the context of the COVID-19 epidemic in the city of Yaoundé. We will be sharing with you our experience. After a brief introduction, we're going to present to you the COVID-19, HIV, and TB data trends in the context of COVID-19 and the strategies that were put in place to mitigate their impact on service delivery, the impact and challenges on the organization of service provision, and the lessons learned will also be presented. Camaron is a country with 26 million inhabitants, of which 3 million live in the city of Yaoundé. Both at the country level and in the city of Yaoundé, we experienced a drop in the HIV prevalence within the 15 to 49 years age group from 5.5% at the national scale to 2.7% between 2014 and 2018. Then in the city of Yaoundé from 6.1% in 2011 to 2.4% in 2018. As at the 30th of June 2020, 65% of people living with HIV had access to antiretroviral therapy. We have about 40,000 new infections yearly, and 6 out of 10 new infections occur within the 15 to 29 years age group. In 2014, the country committed itself to achieve the 1990 targets, and in 2016, the WHO test and treat strategy was adopted by the country. With the occurrence of cases of COVID-19 around the world, the country was on alert, and this led the country to conduct an assessment of the risk of importation of the coronavirus at the country level. A response plan was developed. The National Emergency Operations Center went on an alert mode, and the surveillance system was reinforced, especially at the level of the borders, and the first treatment center was set up, and this was between January and February 2020. As early as the 6th of March 2020, the first 2 cases of COVID-19 were reported in the city of Yaoundé, and the incident command system at the national level was immediately activated. After practically 1 month of incident management at the central level, the process was progressively decentralized as at the 2nd of April 2020 with the activation of the regional incident management system in the central region, which has as capital city Yaoundé, and progressively decentralization went right to the district level with the involvement of the local councils and communities. The country response plan for COVID-19 was made up of 4 main axes, notably active case finding, in which we had testing and contact tracing, the management of confirmed cases in treatment centers that were opened throughout the country, social regulation with the closure of borders. Schools were also closed. The wearing of the mask was imposed to all the populations. Gatherings were restricted as well as movement. Governance and accountability were also part of this response plan. With respect to COVID-19 data trends in Cameroon and in the city of Yaoundé, you can see from this map that the country faced a widespread epidemic with all the 10 regions of the country being affected. The city of Yaoundé had accounted for 30% of the cases of COVID-19 that were reported at the country level as at the 2nd of September 2020. As at the 2nd of September 2020, we had a total of 19,000 cases reported, of which 18,000 recovered, giving us a recovery rate of 94%. The total number of deaths was 414 with a fatality rate of 2.1%. As at the 3rd week of the month of June, we started noticing a drop in the number of cases that were reported at the country level. As far as the city of Yaoundé is concerned, the drop was noticed as from this 1st week of the month of June, showing how effective the decentralization process was. The city of Yaoundé accounted for 22% of the cases of deaths that were reported as of the 4th of September 2020. The health personnel was highly affected by the COVID-19 in our country, with a total of 814 cases that were reported, of which 20 cases of deaths. And the health personnel accounted for 4.2% of all the confirmed cases in the country and 4.8% of all cases of deaths at the country level. The city of Yaoundé alone accounted for 7 cases of death out of the 20 cases that were reported in the country. The highest morbidity was reported between the 20 to 29 years age group, with a peak between the 30 to 39 years age group, be it at the country level or in the city of Yaoundé. The highest number of deaths were reported within the 40 to 79 years age group, with a peak between the 60 to 69 years age group. As far as HIV and TB data trends are concerned, with the onset of the epidemic, develop an operational contingency plan to ensure a continuity of service provision and to ensure staff protection. Those were the main objectives of this contingency plan. The main components were maintain coordination of activities at site level and above site, to prevent infection, prevent and control infection, that's with regards to staff and clients. A reorganization of the testing and linkage services was done. A reorganization of patient flow and a reorientation of activities to reduce waiting time. And catch-up activities were planned as soon as a positive change was observed in the evolution of the epidemic. With respect to testing and linkage to treatment, we observed a drop between the month of February and March of this year, dropping from 76% in February to 68% linkage rate in the month of March. Then progressively, there was a slow pickup between the month of April and June. We see in the month of June, we went right up to a 72% linkage rate. And this is as a result of activities that started being accelerated due to the drop in the number of cases in the 1st week of June. Index case testing started accelerating. Community testing activities were progressively being reintroduced. But however, when compared to the first semester of the year 2019, the year 2020 experienced the greatest drop in the number of people tested for HIV, with a practically a 30% drop in the number of people tested for HIV. An increase in the number of patients using regularly antiretrovirals was observed between the month of January and June 2020. But however, compared to the year, the period 2018 to 2019, we experienced a drop of 32% in the number of new patients enrolled on antiretroviral therapy, compared to a 15% drop between 2018 and 2019. Patient attrition was avoided with the strategies that were put in place, notably home deliveries of antiretrovirals, a revision of patient flow, reminder calls that were reinforced, and the scheduling of appointments by cohorts of patients. As far as the notification of TB cases is concerned, compared to the first quarters of the years 2019, we had a 26% drop, representing the greatest drop between 2000 and the first quarter, the second quarter, the third quarter of the years of 2019 and the year 2020. The strategies that were put in place to maintain HIV and TB services continuity and mitigate the impact of COVID-19 epidemic, we had coordination that was maintained at site level and above site. Meetings were frequently held online. Data reporting was also maintained. As far as infection prevention and control was concerned with respect to staff, rotations were put in place to avoid exposition of staff to the infection. Community activities were discontinued for some time. Protection measures were taken for the staff. As far as clients are concerned, their patient flow was revised and appointments were scheduled by cohorts. As far as the reorganization of testing and linkage strategies is concerned, there was an intensification of testing at all entry points with a high yield. Starter packs of antiretrovirals were put at the disposal of doctors so that initiation could be done immediately in their offices. Follow-up calls for all newly initiated clients were also reinforced. The reorganization of patient flow and retention activities to reduce waiting time was also done. A pre-packing of antiretrovirals was done in such a way that when patients came for their appointment, they could easily pick up their medications and leave the facility. Home deliveries of antiretrovirals was also done, as well as deliveries in offices and other locations as per agreement between the service provider and the client. We planned catch-up activities once a positive change was observed in the evolution of the epidemic, notably the introduction of self-testing. Mobile units had to be deployed to support facilities in the testing and linkage strategies. Community testing was planned to be reinforced. The viral load campaign was also planned, and we also planned a return to care campaign to bring back to care all those who had defaulted. What impact did we observe during this epidemic on the service uptake and delivery? The main challenges we had, firstly, was the stockout of antiretrovirals, which did not allow us to provide multi-month scripting to our patients. Staff rotations in health facilities did not allow us to provide services as expected. Some of our staff got infected, and from clients, there was a fear to use services. As impact, the relocation of services in some facilities in limited spaces, which did not ensure confidentiality in service provision. There was also the discontinuation of activities at the community level, which was a hindrance to the achievement of our objectives. In one of our facilities, antenatal care and PMCTC services were completely discontinued. We learned a couple of lessons. Firstly, the sustainability of service delivery requires innovative approaches, and these led us to develop a contingency plan which took into consideration innovation. Planning to anticipate helps mitigate impact, and through our contingency plan, we planned ahead of the incident to reduce the impact. Differentiated service delivery was a core component of service continuity, provision of service continuity, and it's through differentiated service delivery that we succeeded in mitigating the impact of the epidemic on the service uptake and delivery. Thank you for your kind attention.